So the next case is a 67-year-old lady. She presented with steatorrhea, weight loss, and jaundice last month. CT showed 5.4 centimeter pancreatic tumor centered at neck extending to the head and body of pancreas, encasement of the common hepatic artery, SMA, and obliteratory of the portal vein, SMV, and also splenic vein. EUS plus FNB and ERCP plus stenting was done last month, showed 4.1 centimeter hypoechoic mass at head of pancreas, SMA involved by the mass. Proximal CBD was dilated up to 16 millimeter. Left IHD was dilated up to 5 millimeter. Difficult cannulation was encountered, required EUS rendezvous ERCP to obtain the biliary access. Plastic stent was inserted for biliary drainage. FNB results show a typical glandular proliferation. Underlying pancreatic adenocarcinoma cannot be ruled out. She was reviewed by surgical team and commented inoperable. So these are the CT findings and also the ERCP image. Today we are going to perform ERCP plus or minus FNB and also plus or minus biliary self-expandable metallic stent by Professor Moon.
Hello, welcome, and we are in the middle of something. So initially we wanted to proceed with US for tissue acquisition first, but when we put in the linear scope, we found that actually there's appears some structure over the first part of the duodenum, D12 to be exact. So given the history, highly suspect there are probably some tumor invasion causing some sort of luminal narrowing over the D12. And because today another main aim is to achieve biliary drainage by metallic stent, so we changed to a ERCP scope to assess the luminal narrowing, which Professor Moon very expertly intubate. Despite the narrowing, he could intubate into the D2, which we are seeing the major papilla. It appears quite normal. Contrast. And with the plastic stent, and we cannulate alongside, and we did a sphincterotomy, and we're trying to use subcontrast to confirm the position. And actually, previous history, last time the ERCP could only be done by RV, and actually it did demonstrate quite a long stricture.
Very nice, Mark. Thank you for your great explanation. Good afternoon. Welcome to our room. So this poor lady had a non-resectable pancreatic cancer, and local expertise did the ERCP but failed. So they did nicely US guided rendezvous cannulation, and then put the plastic stent. But they only put the plastic stent, they didn't do any sphincterotomy. So it's 1 month later, we would like to check two things. One is the tissue sampling, because the first trial of, at that time, FNB was inconclusive. So our role is, number one is tissue sampling, and number two is exchanging the stent with fully covered metal stent. So now still tissue is the issue, as you know it. There are two kinds of the tissue sampling. Even pancreatic cancer having obstructing cholangitis, we should perform ERCP. Still, we can do the transpapillary tissue sampling using forceps on stricture. But the nature of the kind of stricture is extrinsic compression. So the accuracy of transpapillary forceps biopsy is lower than intrinsic mass lesion like a cholangiocarcinoma. So digging with US FNA from outside of the stricture is much better. So now we can use US FNA for FNA and B for this purpose. So at first we tried the insertion of scope to the duodenum, but we can imagine it make a duodenal invasion at D1 time, and proximal part of ampulla is invaded. The scope is barely inserted through the D2 portion. So now we are looking on the stent, and then we are doing sphincterotomy at first. So we should exchange the scope with echo endoscope for tissue sampling. So during another room, we did successfully introducing guide wire and removal of plastic stand. It was a 10-flange plastic type, street type, and Marc did successfully remove inside of guide wire. So at first, the plastic stand, we introduced the guide wire over the plastic stand, and we did the sphincterotomy successfully and removed the plastic stand. Now leaving guide wire inside the bile duct, like a fluoroscopy, you can see the very typical distal bile duct structure on fluorogram, and now structure is very tight and very long. So we are changing with the metal stand. There are two kinds of metal stand. One is uncovered, another one is fully covered in metal stand. Also, we can use partial covered metal stand. Still, there are controversy which can be the best, but personally, I like fully covered metal stand. Not only the longer stand patency, but also it's exchangeable. We can remove it and changing with a new stand. So today we are using very typical fully covered metal stand. Maybe Marc will explain to you.
So maybe you can zoom in a little bit. This is a Wallflex, very fully covered metal stand. Because the structure is quite long, so we plan to put in an HCM long stand. It's a rapid exchange one. So under fluoroscopy, we can see the radial opaque marker is well inside, bridging the structure, and then so as usual, we also and fluoroscopically and also endoscopically, we want to see the yellow marker
We have
before
6 centimeter.
we
6 centimeter. Okay.
before we.
Professor Moon, do you think the HCM stand may be too long for
It's
this
too
one?
long, so we are exchanging it. So it looks like a long structure, but patient bile duct a little bit shorter than usual. So maybe 8 centimeter can block the contralateral intrahepatic side. So maybe 6 centimeter is better in this case. Okay, Marc, could you continuously?
Yes, I agree. So actually, this case, some interesting point because the patient has currently has a duodenal stricture over D12. So we had some discussion just now off air whether the patient might have developed duodenal obstruction subsequently, which we think is possible. But I think here still very indicative to put in a metallic biliary stand for two reasons. First, we can first of all secure the biliary drainage, and because actually the duodenal stricture is actually quite short segment. So if in the event that she does develop the duodenal stricture, possibly amenable by duodenal stenting, and which because the major papilla and also the proximal part of D2 is not involved by the tumor, so we are hopeful that the metallic stent is going to work quite well.
So what's your personal preference about fully covered stent comparing with uncovered metal stent in Hong Kong?
I think it depends on also the etiology of the disease. Usually, for example, there is also a different school of thought. So for uncovered metal stent, we of course, first of all, it cannot. It probably has less chance for migration. But then, if it's a tumor case, we always concerned about tumor ingrowth, and that any further manipulation, for example, removal, would be almost impossible. So.
Okay, this system is a shock guide wire system from Boston Scientific. So after catching the guide wire by operator, stent is smoothly introduced the kind of long stricture. And now this is a distal part and almost.
We see
The patient is bile duct is too short, right? Even
Yes,
6 millimeter is
quite short.
almost a hilum.
Yes,
Okay, we can adjust after deploy the proximal part. So you can see the radio opaque mark on distal part. It means limitation of the recapturing. With that kind of until the distal radio opaque mark, we can recapture again. And, okay, you can see the yellow mark on here. Yeah. Okay.
I think the good point here is that there's still some space over the D2, so some leeway for us to adjust the outer length, the distal end of the stent.
Now my assistant is deployed carefully. A little bit slowly.
Now it's teamwork, and we open up slowly.
And we should make sure. And is it okay? And there is maybe hilum below the hilum, right?
Below the height.
Okay. Keep going
I think
slowly.
it's fine.
Slowly.
As far as they actually got about 1 centimeter outside the pillar, should be okay.
Keep going.
I think here the point is we don't want to cover the hilum being a fully covered metal stand. So in case we are a little bit concerned about the stand is too much inside, because the D2 has plenty of space, so we can leave it a little bit more outside. I think it still would be very safe.
So perfectly done. Now we saved the hilum, and this stand is fully covered the metal stand from Boston Scientific. Also, you can see there's some kind of loop on distal part. It means you can make easy removal using that kind of loop.
Yes, and we see a
gently
lot of
remover.
power drainage, excellent air collector over both
And
sides.
Remover of the introducer system should be the slowly, because a long stricture. Sometimes the olive can capture on the stricture. Slowly, and push the scope. And okay.
Okay.
Now
Okay.
the olive is safely removed, and we don't need a guide wire more.
Yeah.
So we didn't see the US guided lung review, but for the checking the previous procedure, nicely did the hepatic puncture and guide wire introducing to the integrated fashion on duodenum, and did the plastic stand. And now today we changed with fully covered metal stand. Now nicely deployed. We saved the hilum and well located. Well means you should keep in mind from the beginner that kind of fully covered metal stand, one of the problem is migration. So theoretically, center portion of stand should be on stricture. So without this kind of concept, we can call it watermelon seed effect. It can migrate for distally. So now, as you can see, the floral, the center portion is exactly center of the fully covered metal stand.
Excellent placement, and we are not we are very reassured because air collector went over both sides of the IHT.
Okay, take the endoscopy view. Again, with the kind of fully covered metal stand, we can exchange the stand after clogging and that kind of thing. Now, maybe we can remove the scope, right?
Yes, and during scope removal, probably we can appreciate a bit of a stricture over the D1-2 junction.
Yes, we want to show that kind of duodenal invasion of D1, typically like here, and mass is invaded to duodenum. And maybe we need the noria to have MBI to see the surface structure, and now it's severely obstructed. So if failed to entering the duodenal scope, you can use balloon dilatation or occluded balloon method to push the scope over the balloon catheter.
And in the event if the ERCP scope really cannot go inside, there are other means for some US guided biliary drainage.
Yeah. Here is very expert about US guided drainage.
Yeah,
So
thank
we
you,
don't mind
Professor Moon.
about
Thank you, Marc.
one.
The standing was perfectly done. Yeah, thank you so much.
Thank you.
Thank you.
Now we are doing second work, tissue sampling, digging with US FNA. Now we are using biopsy needle. Yesterday we showed the Francine needle, newly one acquired S, and now at this time we are using another tissue sampling needle, FNA needle. Maybe Marc explain it during my procedure.
So this is a Procor 20 gauge needle, true cut, and so we are in D1, and Professor Moon identified lesion and very nice and crisp puncture, and because the patient previously had previous attempt as well, and but unfortunately inadequate tissue, so this time we actually applied the suction as well.
And 20, larger size.
Yes, and also a bit of a larger size of a needle.
No problem. Bleeding is no problem. So we are doing as usual patient and marking and the penny and every procedure to get a better tissue. And the first one was inconclusive. Now we should do the larger working channel, larger size of the needle, and to get more tissue. Okay, maybe it's finished to our procedure.
Okay.
Thank you.
Thank you.
Thank you. Thank you.
Enjoy
Professor
another
Moon. Thank you.
procedure.